Afternoon. I'm Dr. Joseph Geenan. I'm a past president of ASGE in 1982 to 1983. And we have Dr. Kirsner here. Dr. Kirsner, would you introduce yourself and tell us about yourself?
Well, I'm Dr. Joseph B. Kirsner. I'm 96 years of age, and I've been on the faculty of the University of Chicago since 1935, but involved in gastroenterology since 1936. And I first then joined Dr. Walter Palmer and first began to learn the details of the gastroenterologic profession.
Dr. Kirsner, why don't you tell us about how you got into medicine and then how you got into gastroenterology?
Well, I'm originally a Bostonian. I was born in Boston and educated in Boston, went to medical college at Tufts, and then to medical school at Tufts Medical School, and graduated in 1933. After I graduated, that I hadn't had enough clinical exposure, and I sought out another GP hospital and ended up purely by chance at the Woodlawn Hospital in Chicago, which was a well-known general practitioner hospital headed by a man by the name of Dr. Rollo K. Packard, who was an excellent surgeon. There were excellent GPs there. But as time went on, I decided that GPs didn't know as much as I thought they might, and so I decided to change course. I hadn't known when I chose Woodlawn Hospital that Woodlawn was located on the one side of the Midway, and opposite was the University of Chicago. And I, incidentally, at the Woodlawn Hospital, I met my future wife, and we were married in January 1934, and she became a very strong support and even advisor, and we both decided that I should continue on with more education and become an internist. Well, I also attended some of the local medical meetings, and one day I was invited to grand rounds at the newly established University of Chicago Hospital, and that turned out to be a transforming experience.
Why was it that way?
Well, the U of C new hospital was a unique place. It was developed by a group of Baptist men of great energy and wisdom, and they decided to establish a hospital that would be full-time faculty. There would be an endowment for patients. It would be specially oriented from the very beginning. And research was a very important activity, and in fact, in the Department of Medicine, you couldn't advance significantly unless you did important research. And that whole experience, that one-day experience, just changed my view about where I should go, and I did manage to get an appointment late in 1935 in the General Medicine Clinic, and assigned to the allergy department in particular, where I began to learn something about immunology. After I'd been there about a month, I asked the director of that unit what was the nature of his research, and he made the startling response, "I don't do research now. We know everything we need to know."
In allergy.
And I immediately started looking for another position. At that time, a fellow who had been working with Walter Palmer left, and I asked Palmer to give me the opportunity, and he did.
Palmer was chief of GI at...
Palmer was chief of GI. The hospital had been opened in 1927, and so I began with Dr. Palmer in January 1936. And of course, Rudolf Schindler had come from Munich, Germany in 1934, so it wasn't very long before I met him.
What kind of research were you doing with Dr. Palmer before Dr. Schindler?
Dr. Palmer had worked with Bertram W. Sippy, who was known for his work on peptic ulcer and ulcer treatment. And so peptic ulcer was the main problem of Palmer's interest. And he decided that if I was going to be in academic medicine, I needed more training, and I decided to enter the PhD program here at the University of Chicago in the biological sciences. And I took on as my subject alkalosis, which is a common complication of the SIPI treatment.
Certainly.
And I got a PhD here in 1942. That was incidentally the same year that I got certified in gastroenterology by the newly established board of specialties in internal medicine.
How did Dr. Schindler get here? And then let's talk a
Schindler,
little bit
well,
about him.
Schindler, of course, had been himself a soldier in the German army during World War I and was aware of the GI complaints of the soldiers and felt that he needed to define the diagnosis better, because in Germany they had health insurance, and if you had a diagnosis you could get compensation. So he felt that the gastroscope, which had been in use in Germany in one form or another since the middle of the 19th century, he started using an instrument called the Elsner gastroscope. He didn't like it very much, but he used it extensively and became known throughout Europe for his skill with holding the head. That was the job that his wife Gabrielle had to do, was move the head synchronously with the way he introduced the instrument. One day when he went to Paris without her, he actually experienced an accident because she wasn't holding the head.
Oh, boy.
So she was my own teacher in holding the head, and Schindler was the one who taught me gastroscopy.
How did he get to Chicago, though, from Germany then? What made him come?
He had been, he had fired an employee because he felt that she was stealing silverware from him.
Okay.
She went to the Gestapo and told them that Schindler's had spoken badly about the Gestapo, and that way, way, way back he had an ancestor that was partly Jewish. Actually, Schindler was a Lutheran. So he was incarcerated in Dachau, and some people argue that he might have been placed in a prison in Munich. And he had become well known enough so that the international group of physicians gathered together, and Walter Palmer had been aware of Schindler, was part of that group, raised enough money, and were able to get him out to come to Chicago as visiting professor. And that's how he began in July 1934.
And you started working with him?
I started working with him probably in 1937, and in time became his assistant, so that on days when he felt that he couldn't come in and carry out the program, I would get a call from Mrs. Schindler and say, you should do the gastroscopies, and Dr. Schindler will hopefully be back in a day or two.
Was this still a completely rigid
It
scope?
was
or
a semi-rigid.
Yeah.
That principle was developed really on the basis of something that had been published in the German literature years earlier by a scientist named Hofmann, that looking around a corner, and if you put lenses at short focal distances from each other on a wire, you can look around a corner. And that was part of the basis of that instrument, the flexibility of the distal end of the instrument.
And Dr. Schindler trained a lot of people while he was at the University of Chicago? Can you tell
Oh,
us?
yes. It became a sensation worldwide, really, and there never was a day when there wasn't somebody here from somewhere on Earth. There were hundreds and hundreds of people who came. I still remember somebody coming to see me from Baghdad, an English physician who was entranced by looking through this gastroscope. So in the course of time, as time went on, Schindler was very concerned about, not making it a major specialty, not competing with surgery or medicine. He wanted it part of a well-organized diagnostic discipline, and he was very careful not to overemphasize the instrument, and that really was one of his main concerns all the time that I experienced my work with him. And gastritis, of course, was a major issue with him, and that It's what led to a difference of opinion between Schindler and Walter Palmer. And in 1943, Schindler left us to go to California, where he had other experiences in California and in South America.
When did he decide to develop a club, the Club American?
So in the course of these early years, he felt there had to be an organization to regulate, set up training standards, and make sure the right people were doing well-trained people were doing this procedure and were evaluating things properly. And he had a map where all these visitors had come, and he chose a dozen individuals who had been prominent in endoscopy, including Ed Benedict of Boston, and including me as one of as the individual. And he set up a program at his home on November 21st, 1941, organized with Benedict leading the discussion against the idea and Schindler leading the discussion for the idea. And of course, it was pretty well ordained that when the vote came at the end of the day, it would be a positive. And he chose the term club, again, not to emphasize that this was a tremendous development. It was another advance, but not the world-shaking event that people might wish.
And he had about 12 physicians there?
12, and they came from different parts of the country. All of them were established gastroenterologists. Some of them were better known than others, but they were certainly all of them very much involved with the endoscope.
Mostly academic physicians, mainly gastroenterologists that were in institutions, academic institutions, or were they some in private practice also?
It was mainly, I think, private practice. There were a few that were involved in academic affairs. I think that you might say that Herman Mersch of the Mayo Clinic was sort of in academic affairs.
You tell me about did you have bylaws? Or
so we set up, Schindler worked with lawyers and set up a constitution and bylaws. The interesting thing about the bylaws was Article 7, which was defined that after 20 years this organization should be dissolved as no longer necessary, that it would be incorporated into the fabric of gastroenterology and medicine generally. And that turned out to be an article that was a source of much discussion. And I remember that when I was president, we had discussed that at great length and decided then to dismiss the principle and not get involved with dissolution.
What year was that? When were you president? When were you president?
I was the 6th president. I think it was 1948. There was a lot that happened before then, of course, because
tell us about the dues. And
I was the first secretary treasurer. The dues were $10 a year, and the only requirement was to follow the standards of the endoscopist and to attend meetings. And it was one of those situations where the membership steadily grew, and an annual meeting was held at the Hotel Claridge in Atlantic City in 1942 on gastritis, which was an important subject, of course, with Schindler. In 1943, they had a meeting on the differential diagnosis of gastric ulcer and gastric carcinoma. And then the third, I think they had a discussion of the limitations of both röntgenology and endoscopy. I myself left the organization in 1943 to join the Army for World War II and turned the secretary-treasurer duties over to Marie Ortmeyer and picked them up again when I returned from overseas at the end of '46.
How did the name change? When did the name change?
Well, as the organization grew and as it clearly was improving in technology and in importance, it it became a subject. It seemed that the club did not reflect its expanding dimensions, and so I think eventually, I think it was in 1961, that the name was changed to the American Society for Gastrointestinal Endoscopy.
Between 41, when it started, and 61, were most of the endoscopy done in academic centers or in private practice? And how did the group get along with AGA, the American Gastroenterological Association?
Actually, Schindler, even before the meeting, organizing meeting was started, had written to the AMA, the American Surgical Association, several other major organizations, trying to point out the importance of the method, but not creating another major discipline. And we had no problems with any of these organizations. I can't recall any particular situation. It was one of a steady expanding growth, as each year there would be new developments. And of course, a major development was the Basil Hershowitz's work with the fiber optics.
And that was in about 1969 or something.
That came, I think it was earlier in the 50s.
And then Larry Curtis and Larry Curtis and Gene Overholt.
Right. Incidentally, Peggy Kirsner has written a detailed account of the organizing meetings. It's published in Endoscopy, if anybody was interested in reading about it. It was, for me as a young physician, it was a very exciting day to be part of this. Japanese, and they kept making developments in their endoscopes, the Olympus and the Machida Company, and as the technology improved, the usage improved, and it became increasingly part of the daily work of the gastroenterologist. And that's a trend that continues to this day. There was a time when I came back after the war service, when we had a relationship with the endoscopists from the Aichi Center in Nagoya, Japan, and they were superb endoscopists and did a great deal to enhance the quality of the program and the frequency of the usage of the instrument. So it was a good illustration of how skills and experience made a big difference in the growth of the organization.
And I think in the early part of the 20th century, most of the endoscopy was done in Europe.
Right.
Most of the endoscopy was done in Europe in the early 1900s, and
yes.
I think many of our people went over there to study as
yes, no question. That's how Marie Ortmeyer came upon Schindler in the first place. She was looking at a bookstore in Vienna, I think, and noted a book written by Rudolf Schindler on Lehrbuch der Gastroscopy, colored photographs. And she was the one who told Dr. Palmer about this. And on one of his trips to Europe, he visited Schindler. And so he was aware of what Schindler was doing before Schindler was brought here. And in the meantime, gastroscopy just simply flourished all over the world, certainly over the United States.
What about the gastric camera? Did you have much to do with the gastric camera?
Schindler played around with it for a little while, but I don't think that he was very impressed with it, and we never did use it here. Also, we one summer worked together to try to develop a better instrument that would take pictures. And we failed in our goal, and I think that was a time when two people from Rochester, New York, working with the Eastman Kodak Company, were able to develop an improvement in that area. There are all kinds of improvements that used to come without end. You'd think, well, maybe we've reached the end of the line in this. It seems that every year there's something else that comes along that makes a difference. And, of course, it's hardly necessary to explain what the status of it is today. It's an indispensable part of our work.
Where do you think the future of endoscopy is going to go? The future of endoscopy, where do you think it's going?
I think the future is open. It's wonderful. It's going to increase. I'm impressed by the fact that they're applying the physics of optics. I think optical apparatus will steadily improve, and of course you've heard about this remarkable microscope that was put at the end of a gastroscope in Mainz, Germany. That's another development. And in particular, the interventional use of the endoscopic technique has been remarkable. It has enabled us to carry out controlled studies. We can take biopsies and study the tissue. This has become usage, and there are so many other applications of the interventional technique. You told me that they were expanding the operative approach with the gastroscope. I myself have not heard about that.
Yes.
But I think it's an example that some usages, additional usages, will be found for that overall technology.
They're now they're doing in animals, they'll do an operation, they'll open the stomach and then take the gallbladder out and close the stomach and
Remarkable.
Bring it out without any incisions. And I think they'll be doing a lot of things that way in the future. They're doing it in animals now.
That's remarkable.
It's just getting the necessary equipment, and you know that'll happen. They'll get the correct equipment.
Yes, there's no question that it is an indispensable part of gastroenterology, and you cannot be a really bona fide gastroenterologist without being an endoscopist.
What do you think was your most exciting time in gastroenterology and endoscopy?
Oh, that's hard to.
You've had so many experiences. And
I've had a lot of experiences, but I've had an experience here that I thought was of interest, even though it's recent. We had a patient who came to us one time with severe upper abdominal pain, and examinations disclosed that she had had a cholecystectomy years before. So our endoscopist carried out an endoscopic procedure and found multiple stones in the bile ducts.
Yes.
And with skill and patience, in one setting, he removed 14 stones from those bile ducts,
Right.
and in effect cured that lady. She's not had, it's been at least 5 years since then, and she's not had another episode of pain. And I thought that was a remarkable demonstration of the usefulness of the technique, the skill and patience of the examiner who did the whole procedure.
Yes.
But I'm sure people have had an even more exciting experience.
And that's a remarkable cure for the lady, and she certainly thought it was exciting, I'm
Right.
sure.
Goodness knows what might have happened to her if we didn't have an endoscope.
Right. Tell us what you did with the American AGA, the American Gastroenterological Association. How were you involved in that, and how were you involved in the Liver Society?
Well, I was, of course, always been in academic medicine, and while my interests included the endoscope, I had interests in other areas, and some of it was related to the people I had around with me. We had one individual who was interested in the liver, and we did a number of studies that were useful. I didn't think that they were particularly noteworthy, so that I was a friend of Hans Popper, and of course everybody knew that Hans Popper was interested in the liver. And in 1948, he invited me to join him and others in forming the American Association for the Study of Liver Disease. But another experience that I'd like to talk about, because it involved the National Institutes of Health.
Right.
I had done research before I went off to the war World War II. And so I resumed in 1946-47 after I had returned. And so I wrote out a grant on peptic ulcer and sent it into the newly established NIH, and it was rejected without explanation. I decided that I was rusty and needed a little more time, so 2 years later I wrote another grant, this one on inflammatory bowel disease, and this was rejected also without explanation. And was upset. I had been in the war, I was in dangerous situations. I thought I deserved at least an explanation.
Yes.
And so I decided I was going to investigate the NIH. And I knew one senator, and I knew of the other senator in the state of Illinois as starters to investigate the NIH. But I had the wisdom to talk to our dean, Lowell Cockashall, who had been in Washington, also was a war vet, and he calmed me down and said, let me look into the matter. And it turned out the first grant had been looked at by a physics study section, and they didn't know what I was talking about. The second was looked at by a chemistry study section, same experience. So we realized that medicine was not even represented in the new NIH. So I called Floyd Daft, who is the director of the Arthritis and Metabolic Disease Institute, and he picked up on it and was in Chicago with his deputy in 48 hours. And in my office, we formed the General Medicine Study Section, which turned out to be a very, very important source of research support and training support for gastroenterology.
For all gastroenterology.
I thought that was an important
Yes,
NIH development, and I actually worked with the NIH for over 20 years after that, and that was very important.
Are you surprised that the small gastric club of 12 people turned out to be such a huge organization?
I'm not surprised at its growth. I'm surprised at how it turned out to be so dominant, and all I can say is that curiosity, technology, research are all wonderful things, and they can lead to some great developments. And I think gastroscopy has already had its day, but it will have more days of accomplishment.
What do you think the vision of the club was initially with the gastric club?
I think it continues to have a responsibility to avoid it being misused. There are some people who feel that there is some over-testing, they're not entirely necessary. I think that may continue to be an issue. I think the society needs to maintain a very active role of education, make sure the training standards are reviewed periodically so they're up to date. And as the technology itself expands, the standards change. So there has to be a periodic review of standards. That's so important for anyone getting involved with what turns out to be a very miraculous but potentially could be dangerous in the wrong hands.
You think endoscopy should be limited to gastroenterologists, or do you think surgeons and family doctors and internal medicine people can perform it if they're trained properly?
I think that the person who does an endoscopy has got to have some knowledge of the GI tract. I don't see how you can rely on an individual who has not had some experience with GI. I myself would favor basic GI training as a baseline for the endoscopist. I think in the long run it will be better for the patient, it will be better for the examiner, and I think it will be the only way that we'll make new discoveries. So I think it's an internationalizing kind of experience, and
I think so too. I think I know endoscopists for every place in the world too, and they're always very excited to talk and get together and discuss things. And it's really a camaraderie that we don't have in other organizations.
Right.
I think people really get along better. I think they understand each other better.
And the most important, it has actually been a major, major factor in the growth of gastroenterology itself. And of course, we've always felt, at least Walter Palmer and I always felt, that you needed to be a good internist to be a gastroenterologist, just as you needed a good internist, be an internist to be an endocrinologist or any other specialty. I think you need a broad base because we're all interconnected.
Dr. Kirsner, why don't you tell us about your time at the University of Chicago and how you developed the programs, and especially inflammatory bowel disease?
Well, I had studied medicine in Boston and had been at major hospitals in Boston, but I cannot recall ever seeing a patient with ulcerative colitis. And in 1936, I was making rounds here, and with Palmer, and we saw this lady who was really very sick, emaciated, and critically ill. And I asked Palmer, what was the diagnosis? He said, well, she has ulcerative colitis. And I said, what is that? And he said, I don't know. And that's what started me on IBD, and I got involved in so many different aspects of it, immunologic. I've spent my life, I think, developing gastroenterology as a specialty, and was involved in all these societies because of that particular interest. And every one of them has grown. Every one of them is alive today and functioning and making a contribution. So.
But I think you're known as the world's expert in inflammatory bowel disease. You're the father of inflammatory bowel disease, I think.
Well, some people
world.
told me that. I've also been called the grandfather of gastroenterology.
I think so too.
But which I'm happy to have. But I'm so impressed with the young people today that are going into the field. I think we've had some remarkable young men and women who become gastroenterologists. And
how many people have you trained in inflammatory?
Oh, at least 250. They're all over the world, and every one of them has been a success.
And many of them are heads of departments.
Many of them are chiefs, chairman of departments of medicine, chairman of endoscopy. We've populated all the gastroenterologists in the city of Chicago. Northwestern, Illinois, are all JBK trained gastroenterologists.
What do you think was your most exciting research in inflammatory bowel disease?
Well, I think when I developed an immune-mediated ulcerative colitis and demonstrated immunologically that it was caused by immune complexes, other laboratories confirmed it. One laboratory confirmed it and didn't give me credit.
Oh, my goodness.
But the rest of the world did. But I think developing IBD as a broad-based challenge involving not only immunologically, but the nature of inflammation, some basic science relationships there.
Getting more exciting as we have more drugs to treat this and try to hit.
Well, I think we have
disease.
to be careful because, in fact, I just wrote a little commentary. I said the new drugs are so much more efficacious, and we're going to have more new ones, but we shouldn't forget that IBD involves a sick person, and we should pay attention to the patient, not just write a prescription.
Exactly right. They take a lot of care, as you know.
Absolutely.